James es de Canadá, es uno de los pioneros en todo lo que tiene que ver con el proyecto, o con proyectos de HL7 en código libre, digamos, o permitir el acceso. Yo creo que es la herramienta más utilizada en toda Argentina para usar herramientas de HL7, tanto ahora los servidores Happy Fire como todo lo que tenía que ver con versión 2. Digamos, así como tiene su parte gratis, digamos, o pone disponible el servidor de Fire, también lidera la parte técnica de Smile, el Clinical Data Repository, digamos que ese es su producto o su empresa, y en ese aspecto es líder técnico. Digamos, no es nada extraño que su empresa se llame Smile y que el producto sea Happy, porque vive con una sonrisa en la cara. Así que le damos la bienvenida a James y espero que disfruten de la charla.
Bueno, vamos a empezar con una disculpa. Esta plática será en inglés, lo siento, pero en estos sujetos técnicos creo que mi español no es suficiente para poder hablar con ustedes en español, pero si hay preguntas después, me gustaría mucho hablar con ustedes en español. Pero por este momento vamos a cambiar de idioma. I am James Agnew. I am going to do my best to speak slowly. If you guys want to speak with me in Spanish later, I would love if you would do the same. La verdad es que su acento es muy difícil a entender para mí. Bueno, vamos a tratar de hablar en Spanglish aquí. ¿Qué vamos a decir? I have been working for 20 odd years in interoperability. I started many years ago working for a hospital, and I'm going to tell you a bunch about that, sort of where I come from. But these days, I am working for a company called Smile CDR. We are a commercial enterprise who sort of have formed around the Happy Fire open source library. I hope that many of you guys are aware of our work on Happy Fire. As Fernando said, we've been working for, I think Happy just reached its 18th birthday about a week ago. So we've been, for 18 years now, building open source software for healthcare. I'm fairly proud of that. I think it's kind of a fun thing. So let's get to it. So I love this little Twitter exchange. I've been starting with it quite a bit. And I think it's an interesting place to sort of start the conversation about why interoperability, why medical apps, like why is all of this stuff important? And why is this entire movement around the world starting to take place around HL7 Fire? David Jurling, who happens to also be from Toronto, where I'm from, is a pharmacologist and an internist. He's not an informatician, he's not a programmer, he has nothing to do with interoperability, and his conversation has nothing to do with interoperability. And I think that's what makes it kind of an interesting case study. This graph that you see here, I don't know if we have any medical people in the room. I'm a programmer. I love looking at lab tests and I love pretending that I understand them, but I don't completely get what they mean. Every time I personally get a lab test done, I go straight to Wikipedia and I look up what the numbers mean and I try and make sense of it. If any of you guys are geeks as well, you've probably done the same thing as I always do. So I love looking at this. This was produced by a resident, like a medical student who works at a hospital called Sunnybrook Hospital up in Canada. And what's going on here, these are all liver function tests. And the blue line represents liver damage. That's a spike in one of the proteins of the liver. It means that all of a sudden, something went wrong in this patient's body and they started to see this horrible spike in one of their proteins. And this industrious young student took it upon himself to create this Microsoft Excel spreadsheet where he charted what drugs was the patient on, at what moment in time, and what were happening with the liver proteins. And instantly looking at that, I mean, I'm not a doctor myself, of course, and I can see what's going on. You can see right at the bottom, the patient started a drug called Pantaloc, which is an antibiotic, and all of a sudden these proteins started to spike. So that was really easily caught. Now this is not, I mean, it's obviously software. It was built in Microsoft Excel, but there's no interoperability here. Nobody, you know, there's no, this data wasn't coming out of some electronic system. This wasn't automatically generated for a doctor. This was probably hours of work for some poor student who spent a bunch of time building this graph. As happens, you know, you have any discussion on Twitter, a long conversation started around it, starting with this guy who looked at that and said, wouldn't it be great if the patient's EMR, like if the doctor's EMR could automatically generate that graph? And naturally, no, you know, none of these are all doctors. They're not informatics people. They went into this long discussion about exchanging Excel templates with each other and all these horrible ways they could have produced this information that would have been just instantly done if they had any basic interoperability in their systems. And, you know, they don't, sadly. The truth is, as is the case in many parts of the world, in Canada, we love to think that we're doing great in this world. We're not. We're no different than anywhere else. We're just starting down our own journey of building interoperable systems. But I'm hoping that this stuff will change. And maybe the next time this patient, you know, this patient or someone like this patient has a problem like that, hopefully some sort of electronic system will be there for them. So our point today is to talk about HL7 Fire and sort of standards that are coming out in the world and starting to really hit the worldwide stage that will make it easier for us to build applications like this the right way the next time we need to do it. So I'm going to start all of this with a story from my own career. As I said at the start, I've been working for 20 odd years in the health system up in Canada. To anyone who's ever been to my hometown of Toronto, this is University Avenue. We call it Hospital Row. The reason we call it that is there are a number of hospitals all right next to each other. The building on the left is Toronto General Hospital. They're well known around the world for their multi-organ transplant unit and another of other specialties. They're a fairly advanced hospital. On the right is Mount Sinai Hospital and Princess Margaret Cancer Center. Two more fairly prestigious hospitals, each have their own specialties, of course. And so I started here 20-ish years ago, working at Toronto General. I was a programmer, had recently graduated in computer science, thought to myself, it would be fun to try working in the medical field. Let's see what problems we can solve there. The very first project that I was asked to work on, I was asked, we need to build a system that will connect the building on the left to the building on the right. These are two hospitals across the street from each other. We need to build some sort of system that will allow them to exchange some basic data because these guys are not exchanging any data today. And I looked at my boss back 20 years ago and said to him, what do you mean? Like this doesn't already exist? We don't have that system today where data is flowing between two organizations across the street from each other? And he said, no, of course we don't have that. You have a lot to learn about the world of health informatics. He was right. 20 years later, we barely have that system today. I'm going to talk about the technology a little bit, but we have a long way to go in this world, I guess. The system that we set out on building was connecting two hospital EMRs, a system that was called Vista at the time, and a system that was called Cerner PowerChart at the time. We wanted to build a little portal that sat in the middle and aggregated the data from the two of those systems that would sort of let a doctor sign into the system and see results from the hospital on the left and results from the hospital on the right. The net result was this, a system called Patient Results Online. I love looking at this. It's ugly. I realize it's incredibly ugly. By modern design standards, by any objective measure of how you would build a system, this thing is just horrible to look at. But I mean, look at it in another lens. This was written 20 years ago, or 18 years ago, to be truthful, and was a fully interoperable system that within a year of launching, was pulling in data from 5 completely separate organizations and aggregating them in a single portal view. To the programmers in the room, I always think this is neat. This entire page refreshed itself, and this was before the days of like Ajax page requests and that type of thing. We had hidden frames that sat in the corner and reloaded constantly. All these tricks that we had to use to get this page to seem like it was magically reloading itself. It's really neat technology. So we put a whole lot of work into building this crazy complicated system for the simple purpose of getting data across the street. Like, how stupid is that, honestly? But we did. So how did we build this system? I bet lots of people in the room are familiar with this stuff. This is an HL7 version 2 message. HL7 version 2 has existed since the late 1980s. It's an old, kind of neat protocol. People who are good at it love it. I'm one of those people. I'm like to think I'm pretty good at HL7 v2. I love this. I can look at these messages and instantly tell you everything about what this thing is trying to tell you. But let's not kid ourselves. These things are horrible. To any programmer who is looking at modern technology, these are not great. They're difficult to understand. They're not based on any of the technology that powers modern applications. They're their own proprietary thing. So HL7 realized a long time ago they needed to replace this technology with something that was something newer. By 2009, we were deep into building these applications. The patient results online application that I showed you before was, by every measure, it was a wild success. We were seeing, thousands of users every day were accessing data. Patients were seamlessly transitioning care between institutions without any gap in their care. We were really happy with the way that thing looked. So we set about to build all kinds of other applications. I've got examples up here on the screen. We got into building MedRec tools, all sorts of synoptic cancer reporting tools. We had a very early project to do a patient portal, like giving patients some access to their own data. I'm going to talk a whole lot more about patient access a little bit later, but we were fairly early into the world of patient access. We got into referral management, all this neat stuff, but every step along the way, we were held back by the awful state of interoperability technology. So how bad did things get? This was where we started, this HL7 v2 stuff, and I still love HL7 v2. But by the time we hit 2009, up in Canada, we were on this horrible adventure looking at this stuff. I hear a few laughs in the room. Anyone who's laughing knows this as HL7 version 3. This was the replacement for the last technology. And this stuff is so unpleasant to work with as a developer. It's how do I feel about this? That sums up my entire adventure with HL7 version 3. So HL7 Fire, which is our purpose today. I'm going to talk a whole bunch about this new technology called Fire. I hope you guys are already somewhat aware of what this stuff is, because this talk is not an introduction on Fire itself. I want to talk a level above that around what we're using it for and how it's changing the world. But HL7 Fire came along in roughly 2011. So it's a really young standard, actually. It's not even 10 years old at this point. So as far as technology goes, fairly young thing. We took one look at Fire and fell completely in love with it. We thought, this is a breath of fresh air. This is a technology that's going to change the world. So, complete recap of Fire. For anyone who is completely new to it, Fire has tried to do things differently. First off, the Fire standard is a flexible data model, fairly robust, fairly complete for all things healthcare. It's a data model you can use in your applications, whether you're building interoperability solutions, whether you're connecting organizations, whether you're building apps, whether you're building web applications, whatever the thing you're trying to do is, there's this robust data model that underpins Fire that can be used for all of that. FHIR brings with it this lovely, sort of friendly, powerful, modern API for accessing data. If you're a programmer, you're probably well familiar with APIs. If you're not, the general principle here is that, you know, I can any moment now pull out my phone, I can pull up Google Maps. The app on my phone has gone into the cloud, into some server, probably somewhere in California, and downloaded a bunch of maps I can look at. APIs are the concepts. They're the technology that sort of powers that exchange. And we're sort of trying to bring this entire approach to healthcare. They're intended to be this mechanism where if I want to download an app on my phone to manage diabetes, then I should be able to connect into a hospital and download data exactly the same way that I would connect into a map, into Google, and download a map. Finally, and most importantly, you know, we love to talk about technology, we love to talk about data models, we love to talk about APIs. Those two things are important, but what's really important about FHIR is it's a community, and it's a global community. It's this incredible worldwide group of developers who are getting together constantly and solving problems together. So what form does the community take? I've got a couple of photos. This is a FHIR Connectathon. I was looking at this, and I think I recognize Diego Kaminker as being in this photo, and I actually think that he's underneath the caption at the top, so we probably can't see him, but this is a USA Connectathon. This is kind of the focal point of development of FHIR. Every roughly 3 to 4 months of every year, we do a Connectathon in the United States where developers from around the world get together and work together at these round tables to try and solve problems together. Every table is working on a different problem. They are honestly, sort of as a standards geek myself, they are incredible events. You'll have a table that's working on, you know, connecting two EHRs together. You'll have the table next to them working on how do we model medication exchanges for medication order entry, perhaps. You'll have a table with a bunch of Europeans working on international patient care summaries and the transfer of data between countries. Every table has their focus and their thing that they're working on. And most importantly, every person there represents a different perspective and a different organization. This is kind of the magic of what FHIR is providing, is because the technology is intended to be easy to understand. You've got this incredible framework for people of different backgrounds, of different companies with different perspectives to sit down at a table together and solve a problem together. It's honestly a magical thing. The USA is, as I said, the focal point for a number of these things, and it drives me a little bit crazy that I have to travel to the USA constantly to do these things. It's all the worse, I'm sure, from all the way around the world here in Argentina. The USA is a long ways away, but the good news is these events are starting to spring up everywhere around the world. The entire FHIR community process is starting to become this model that we're seeing replicated in every corner of the planet right now, with people trying to achieve that same success with however the health system works in the country they come from. A few examples of those. This is Amsterdam. This is the Dev Days event. I was actually at this event last week. So in the last week, I've been in Amsterdam, Canada, and now Argentina. I'm a little tired from all of that. This is an Amsterdam event. This is an event last year in Hanoi. So the government of Vietnam have started down an adventure of getting a national infrastructure based on FHIR together. They're trying to replicate the Connectathon process themselves with so far quite a bit of success. One more photo to look at. This is Chile, our neighbors just to the west of here. This is a Connectathon that happened roughly 1 year ago. And the good news is, because I know you're all looking at these photos and thinking, I wish I could go to one of these Connectathons. The good news is we're doing one right here. I think this afternoon. So we're gonna have one of these events happen here too. That's gonna be fun. One more word on sort of the Connectathons. This is the growth at USA Connectathons. And if you take the same graph for any of the other places I showed you, or any other place around the world, they all show the same pattern. These connect-a-thons are growing like crazy. They're becoming just these massive events with tons of people cooperating, collaborating, everything else like that, trying to work together to solve problems. One other resource that I would like to draw your attention to, if any of you guys are starting to get, you're getting moving with FHIR, you're starting to try and learn the standard, you're trying to solve problems, I always want to point out chat.phir.org. Chat.phir.org is a free online chat platform. There are people around the world who participate in this forum. It occurred to me at the very last minute, I'm too late for this slide, that I've got photos of the English section on the slide. If I had thought of it last night, I would have swapped this. There is a Spanish-speaking community on here as well. In fact, there are several Spanish-speaking communities on here as well. If you'd rather be discussing this subject not in English, you've absolutely got that possibility. More importantly, there are people 24/7 answering questions on this free resource. So do take some time to check out chat.phir.org. It's honestly an incredible resource as you try to get started with this type of implementation. One of the bits of magic around the FHIR standard is the community process that I've been discussing has worked really well to develop FHIR the standard. It's allowed us to bring in perspectives from all around the world in terms of, how do we model data? How does the health system in Argentina differ from the health system in Canada? How is it different from the health system in Australia? And how do we create an international standard that models that supports all of these different health systems around the world? One of the really neat things about this community process is it has started to spawn all of these other community projects as well. So I'm gonna walk you through a few other community projects that are coming out of the FHIR standard that I think, as FHIR starts to grow here in Argentina, you're gonna start to hear these other names as well. They're kind of sister projects to the FHIR project itself. One of the first things we realized as we started implementing FHIR was FHIR is a great data standard. It's a great way for exchanging lab tests or encounter summaries or whatever, but you can't exchange data if you don't have security, right? We're dealing with healthcare data, it's extremely private, it's extremely sensitive, we've got to secure this stuff. So we started thinking to ourselves, we're taking a modern approach to the data. What would a modern approach look like for building a security apparatus around these data standards? We started looking at how does the rest of the world do this stuff? And quickly sort of realized there's a technology called OpenID Connect, also called OAuth 2. Those two are sort of synonyms. This stuff is super popular in the rest of the internet. And we created a protocol called SMART on FHIR. This is their logo, the SMART project right here. And this photo on the right, I suspect is a photo that will be familiar to many people in this room. I bet lots of you use Facebook, and if not Facebook, you've probably used Twitter or LinkedIn or GitHub or any of the other systems that support the workflow of login with Facebook or login with Google, right? Like we've all done that thing where we tried to sign into a website and we clicked the login with Google button and magically we're signed in. You may not realize this, but what you're doing when you use that sign-in process is using a technology called OAuth 2. And OAuth 2 is this mechanism that allows sort of the transfer, the delegation of access management and authorization between different organizations, between different web applications. So, what we're looking at in this photo is this notion of allowing an application, in this case, it's a thing called Mashable, or maybe it's the New York Times application or something that I'm trying to authorize with Facebook so that it can post on my wall on my behalf. We started looking at what would that look like in healthcare. And Smart on FHIR is a protocol that allows us to bring that same workflow, that we're all so familiar with based on using the web, to healthcare. This idea that if I've got an EMR, like if I'm a doctor treating a patient in an EMR, and I want to launch an app, a customized app, I should be able to click a log on with my EMR button and instantly be logged into whatever the app is. So this screen here is that same, what's called an OAuth grant request screen, but tailored to healthcare now. That's the idea between the SMART protocol, or behind the SMART protocol, and what it brings to the table. SMART is seeing this crazy set of adoption around the world because it solves the important problem of security. And what that looks like is different in every country we go to, of course. In the United States, where SMART was born, they've got a they've got a private system. Everything is private there. And everything is dominated by these great big EMR vendors. So innovation in the US is being led by EMR vendors that are building these smart platforms with APIs on top of their vendor products. We're seeing that like crazy. On the other hand, you go to other countries where you've got a much more powerful public system. Canada is one of those. Much of Europe is like that. Australia is like that. We're starting to see national governments, or sometimes regional state governments, build up smart ecosystems that cover an entire population for a country or for a state. In Canada, we have provinces. We're sort of organized into a bunch of mini health systems by province. And each province in Canada is now starting to look at the idea of what would it take to build a marketplace of these smart applications on top of our infrastructure. In much of East Asia and Southeast Asia, we're seeing insurers. Sometimes they're national insurance providers. Sometimes they're private insurance providers. We're starting to see all this motion towards insurers creating these neat ecosystems. And finally, some of you may have heard of OpenMRS. OpenMRS produced an open source EMR. It's used quite a bit in lower income countries. Primarily, they've got really big install bases in Africa, in some of Southeast Asia. And they're looking at creating a worldwide ecosystem of smart on fire applications for all of the places where OpenMRS is used, which I just think is so cool. This notion that I've spent a lot of time in Vietnam as an example. And in Vietnam, everybody's got a cell phone. They had cell phones there before we did in Canada, just because they jumped ahead of, they moved a generation past the technology that was used for phoning in Canada. And I think they're about to do the same thing in healthcare. They recognize on a national level the value that Smart on Fire brings, and they're looking at this countrywide adoption of ecosystems and marketplaces of applications, which I just think is so incredibly cool. Technology number 2, moving on from SMART. Lots of people, as we started to develop these standards, started thinking, okay, great, we've got APIs, I can build an application, I can go and get some data that I'm looking for, fetch it, pull it into my phone app, that's great. What about the other model, where I want to build an application that gets notified when new data comes along? What about decision support, clinical decision support? How do we sort of support that workflow? A sort of parallel standard that is being developed within the same FHIR community process is this thing called CDS hooks. And CDS hooks is all about this notion that I should be able to subscribe to notifications when real-world workflows happen. So I should be able to create an application that's going to get notified anytime a drug is being ordered or a patient is being admitted or an adverse event happens, whatever the event is, I should be able to create applications that get notified about the event and will do something in response. This slide is an example from their website, and it sort of gives a basic example of what this new CDS hook standard is about. The idea, of course, in this example is that a doctor is ordering a drug called Toprol. The CDS hook service will notify a bunch of connected applications built by individual developers with a specialty in something to launch a set of cards. And these cards are little bits of information that are displayed right in line inside the EMR for the doctor to look at. And for example, perhaps there's information on payment details for that drug. Perhaps there's suggestions for other drugs the patient might try. It might even launch a smart app right in context around what's going on. So all kinds of neat things that can be done there. think I'm going to skip those guys just for time and move on to the final project I want to talk about, which is Happy Fire. Happy is our open source implementation, of course, of HL7 version 2, as well as the new Fire standard. We skipped HL7 version 3 entirely because I did not like that standard at all. Happy Fire these days is, by any measure I can come up with, the biggest implementation of Fire around the world. It's a pure open source library. It is available for use in any product you guys are building. I always like to stress that even if you work for a private company, even if you're working for a vendor building software, you can use this library in products that you're going to sell for free without needing to do anything with the library. You don't need to pay anyone anything. You don't need to tell anyone anything about your use of the library. It is 100% a pure free library for you to use inside your systems. I should also mention we have a new logo. This is our raccoon logo. I don't know if you guys have, I guess they're called mapaches in español. ¿Hay mapaches aquí? Bueno, es. En Toronto es el capital del mundo del mapache. Tenemos más que en nunca otro lugar en el mundo. So we decided that we would make the raccoon our logo. We had a designer build this thing. I think it's kind of fun. So Happy Fire gets used for all kinds of interesting purposes around the world. We've got people building these great big national infrastructures. We've got people who are app developers building apps. We've got hospitals connecting each other, all kinds of fun stuff. So who's using Happy? This is a map that's generated automatically based on our developer documentation. So every circle on this map represents a bunch of developers accessing our online Happy Fire developer documentation. I love this map. I could spend the next hour talking about all of the circles on this map and what they mean. I think there's all kinds of cool stuff that's going on here. This map, I generated this about a year ago, so this is a year old. I should point out, actually, I meant to update this. I went last night after I had finished the slides and pulled up the latest map where I included only the last month of activity on here. I do want to point out, we can see there are two circles in South America, in El Cono Sur. One of those is Santiago, and you can see that's the bigger of the two circles. If we look at this map from the last month, in fact, Buenos Aires is much bigger than Santiago. So you guys are winning right now. So I should have switched the map, actually. So sorry about that, but oh well. Ni modo. Yeah, I'm not going to talk anymore. But if anyone at any point later in the day would like to talk about anywhere on the world here, what's going on in the rest of the world, this is a subject I love discussing because I think it's super interesting to compare and contrast sort of how people are using this library in different parts of the world. What's being done? What are the challenges? How is the health system different? So if anyone wants to discuss that, well, I'll get a chance to practice my español. I do want to change gears, and that's why I'm skipping that other bit. I want to switch gears now to a topic that is just so close to my own heart, and that is this new movement in healthcare around the world that I'm hoping I can get you guys excited about a little bit. And this is a movement towards using the APIs that Fire brings to the table for something that really hasn't happened much in healthcare, and that's this concept of involving the patient themselves. I always think, you know, when I describe this concept to people who are not involved in informatics, they look at me like bewildered. They're like, of course you involve the patient. Healthcare is about patients. And you start to sort of look at what are the challenges there, and you realize that no, we don't typically involve patients in our healthcare at all. I have no idea if things are different here in Argentina. I bet they're not. I bet you guys, just like us in Canada, experience healthcare as a patient as a thing that is done to you. You go to the doctor, you give them a list of problems, you say, this is wrong with me, my finger hurts, and I've been having trouble sleeping, or whatever your thing is. And the doctor spends some time thinking about it and gives you a care plan and says, go away, go do these things. Here's some drugs you should take, here's some exercises you should do. Go off and do things. It's a really one-directional conversation. But we're starting to see this sort of movement around the world towards trying to empower patients themselves to participate in their own healthcare in some form. And that participation will take very different forms depending on the disease, but there are opportunities all over the map for us to bring patients into the conversation. I'm going to focus specifically on one type of digital intervention, one way of involving patients that I think is particularly interesting, and that's this movement towards apps. We are all, of course, I can see lots of people with phones in their hand. I, of course, will not go anywhere without one of these stupid little cell phones in my hand. I don't have a data plan while I'm here in Argentina. And I mean, you all know how that's like. These days, we rely on these phones like crazy. And you spend 5 minutes walking in the street without data, and you realize instantly just how interconnected your life is with the rest of the world because of these cell phones. They are still, like, healthcare is a gap there, right? Has anyone here ever used a cell phone app, a mobile app for managing a condition, managing something like a health problem that was wrong with you? Has anyone ever done that? I see a couple of hands, but not many, honestly. Hopefully that means you're all just healthy and don't need such an app. But I mean, you know, statistics tells me that's probably not the case. So I'm going to spend a bit of time talking about a bunch of work that I've done with a place called the Center for Global eHealth Innovation, which is a research institute in Toronto whose entire research focus is on mobile applications for managing chronic conditions. That's a mouthful, of course. What I mean by that is phone apps for diabetes, for chronic pain, for cancer, for hypertension. These are apps for managing conditions which are very serious in nature. We're a research institute with an aim to commercialization. So our entire view of the world is let's run proper study, let's run clinical trials, proper research on medical interventions, figure out if they work, and if they do, let's bring them to market so we can try and improve, in our case, the Canadian healthcare system. So I'm going to talk a little bit about the good and the bad here, using a few sort of case studies of apps that we've built to sort of show what works and what doesn't. And this stuff, I think it's just so interesting. I mean, my work with these apps has been purely as an interoperability architect. I'm not a graphic designer. I'm not a human factors engineer. We've got these teams of just brilliant people, far smarter people than I am, who sort of design these things, design the medical intervention. I just have the fun task of making the things talk to each other. But a few of our findings here. So, I mean, first off, you know, the first discovery we had was that these things, like I like to call them novel app interactions, are incredibly popular. What I've got here is the example of a chatbot. And I bet lots of you guys have seen chatbots in other contexts other than healthcare. Chatbots, of course, are these neat little systems that pretend they're a human. You talk to them like you're a human, and they answer back as though they were a human. The example I've got on the screen is an app for managing chronic obstructive pulmonary disease and asthma. These are people with respiratory problems. The chatbot helps them discover or self-diagnose what are called exacerbations. These are acute periods where a patient's asthma has gotten much worse. And if you catch it early, then you take a quick intervention, you take a little puffer, and you sort of stop the problem before it gets any worse. We thought to ourselves, how can we make the experience of constantly interacting with an app pleasant for a population that, in all honesty, tend to be quite old? We're talking often these are people in their 70s, 60s, 80s even. And we started thinking, would these people rather than talking to a faceless app, would they prefer to talk to an app that sort of looks a little bit more like WhatsApp? And what we found is that, yes, they love this. Every bit of feedback we got from a population that often had barely used a smartphone showed us that these people just love this form of interaction. And even better, running early sort of clinical trial results showed this incredible improvement. We were able to reduce exacerbations in this patient population by I'm forgetting the number and I should have it on my slide, but it was 20, 30, 40% in some cases. Like it was absolutely incredible. All right, I've been given a 5-minute warning, so I'm way behind. That's good. I'm going to skip ahead a little bit. On a sort of similar note, this is a kit called Medley. This was designed for helping people with what's called congestive heart failure. So this is people that effectively their heart is shutting down. So this is the sickest of the sick people. We designed this thing called a Medley kit that we sent home with the patient. This is interoperability in its greatest form. So we've got a phone that communicates with Bluetooth to a scale, communicates with Bluetooth to a little blood pressure cuff, and every day, twice a day, the phone beeps. The patient hears the beep. They pick up the phone, and it reminds them they should weigh themselves and they should take their blood pressure. This is where interoperability comes to. All of that data gets beamed into their phone and gets transmitted back to their doctor, back in the hospital. And the doctor has instant notification if there's anything that's trending in a bad direction. What did we discover through all of this? We learned a couple of things. First off, we learned that this intervention works incredibly well and is incredibly cost effective. You may be thinking to yourself, you know, an entire kit like that is not cheap. And this is true. We're using really cheap, we're using these Chinese knockoff Android phones. So the hardware is pretty cheap, actually. The scale is a little bit more. The blood pressure cuff is a little bit more. All told, one of these kits costs us about 400 Canadian dollars, 300 American dollars. I'm not sure what that is in pesos, but there we go. But that $300 compares to a cost of about $90,000 if that patient goes into the emergency department just one time. So we have saved, you know, if this intervention works once, it's paid for itself 100 times. It's an incredible intervention with just a little tiny bit of interoperability inside it. One final point on that, the patients that ran in this study, by and large, were even older. Like this was 80-year-old patients tended to be using this application. And one of our biggest surprises was that we found that a majority of these patients started this study without ever having used a smartphone. We found a majority of these patients became Facebook users and went out and bought a smartphone when they finished the study. So they grew to love this technology. They grew to love having a smartphone, just like any of us do. I think that's really neat. I'm going to talk about one more challenge while I'm here, because I'm running low on time, and that is the challenge of service design. So if any of you guys are starting to think, how do we bring patients in? How do we build these smartphone apps ourselves? I want you to spend a minute thinking about this new thing called service design. Service design is an emerging discipline in the world of human factors. I went and looked it up. How do we say this in Spanish? And of course, diseño de servicio. I guess I could have guessed that. Spend some time looking at how we do service design. This is a photo of a place called Chipotle. They're a popular burrito shop up in Canada. I know you don't have Chipotle here, but I'm sure you do have burrito shops. I am a big fan of burritos myself. Chipotle, if you've ever been to a Chipotle, and if you ever visit the US, go to one. They're neat, actually. They are a perfect example of service design. Every single person working in a Chipotle has one job, and they do that one job. The entire experience as a customer is curated for you. They have thought about every possibility for everything you could do, every question you could ask, every special request, every way that you might try and disrupt their process. They've already thought about it. They've done the service design, and they've got this wild process. We try and think about in the same terms in terms of healthcare apps. And I'm going to say, we've built a number of these healthcare apps, and you guys hopefully will try and do the same. If you try and build a healthcare application and use interoperability to integrate it into the rest of the healthcare system, you are going to fail if you don't do your service design. You have to consider basic things. How do you onboard a patient? Like how do you get them registered and connected? How do you make sure that data that comes in gets routed to the right person in the clinic? How do you make sure that there is a person in the clinic whose job it is to check these notifications? What do you do about vacation coverage? What do you do when the device gets dropped in a toilet? There's all these problems, and you have to think about all of them because any one of them goes wrong. your study is sort of, it's sunk. So, I mean, this is it. You have to spend some time thinking about this concept of service design. One final process I'm going to talk about in terms of service design is this notion of how do we get these apps into the hands of patients. This is an emerging area of what we like to call prescription apps. The idea that if I've got a condition, I would get prescribed a drug, that's cool. But maybe in the next generation of healthcare, I'm going to get prescribed a medical intervention app. I'm going to get prescribed a phone app to manage my diabetes instead of just drugs. One of the emerging types of software that's coming along is these application prescription systems. I would highly encourage you guys to check out the website linked at the bottom. This is Digital Health Guide. They're a company in Australia that I am just a huge fan of. They are leaders in the world of healthcare, of sort of app prescription, and they've got a beautiful system. They'd love to sort of discuss that stuff with you. I think on that, given our time, I am going to cut right to the end and say gracias a todos. Esta es mi perrita mexicana, se llama Dharma. Gracias.